Hello, everybody. I'm Steve Silverstein, the Associate Chair for Research in Psychiatry, and welcome to today's Engel Rounds. Our presenter today is Aileen Aldalur, and I'll be introducing her in more detail in a few minutes, but I just wanted to say some other items first about the presentation to the session today. So first, everybody's camera and microphone will be off for the duration of the presentation. We hope people have questions by the end of the talk, and we'll have a question and answer session at the end. If you have questions, please write them in the Q&A box that you can access from the bottom of your screen. Don't use the chat box, which is used for the panelists to communicate. I'll actually ask the questions to the speaker at the end. I'll just read them out of the box. Also, it's very important that we get your feedback on the session today. And to do that, Steve Fasson will post a link to the evaluation at the very end of the talk in the chat box and on a slide, and an email will come out tomorrow with that link as well. Also, Steve's going to post a link to an upcoming presentation. That's part of our 75th anniversary celebration. This is something happening Tuesday, March 6th, or Tuesday at 6. And this is now in the chat box. It's an overview of biopsychosocial innovations and education, moderated by Deborah King and including a number of our faculty members. So I hope to see you there. Today we have Dr. Aileen Aldalur, who will be giving a presentation entitled Promoting Treatment Seeking for Deaf Individuals with Behavioral Health Problems. And I'd like just to say a few words about Aileen. She is currently a postdoctoral fellow in the Department of Emergency Medicine at the University of Rochester Medical Center. And starting in the summer of this year, she'll be a faculty member, a senior instructor in psychiatry. Aileen received her bachelor's degree and Ph.D. at Gallaudet University. And her research interests involve developing evidence-based behavioral health interventions for people who are deaf. I'd like to congratulate Aileen because last week she was notified that she was awarded a KL2 Career Development Award through our CTSI. And the research component of that grant involves testing a cognitive behavioral intervention to promote treatment seeking among deaf individuals with either alcohol use disorder, post-traumatic stress disorder, or clinically significant depression or anxiety symptoms. So we'll be getting an update on that work and what's led up to that today. So without any further delays, I'd like to introduce Aileen Aldalur, who's our speaker for today.
Hello. Thank you for the nice introduction, Steve. Let me go ahead and share my screen with my PowerPoint. Okay, I hope you guys can all see that. All right, if not, someone send me a chat. Good afternoon. My name is Aileen Aldalur. Like Steve mentioned, I'm a postdoctoral associate in the Department of Emergency Medicine here at URMC. So today I will be discussing the work from my ongoing postdoctoral project, which is funded by the National Institute on Alcohol Abuse and Alcoholism. My project focuses on increasing treatment seeking among deaf individuals with alcohol use disorder or other behavioral health problems. Okay, so here's the agenda for my talk today. Just a side note, sometimes when I put up a slide, I might wait a couple minutes for you or a couple seconds for you guys to take a look at it before I start talking. But today I will begin by providing an overview of treatment seeking in the general community and explain how the low rates of treatment seeking is a major barrier to the effective treatment of behavioral health problems. Next, I will introduce cognitive behavioral therapy for treatment seeking, CBT-TS, which is a novel intervention developed to address the low rates of treatment seeking in the general society. I will provide a brief overview of an ongoing trial of CBT-TS being conducted here at URMC for individuals with untreated severe alcohol use disorder, and explain how I got involved and what led to my postdoctoral position. And then finally, I will discuss the deaf cultural community, current health disparities and barriers to treatment, and my ongoing postdoctoral project to adapt CBT-TS for use with the deaf community. So as you can see from the statistics presented on this slide, one of the greatest barriers to the effective treatment of behavioral health problems is that individuals who could benefit from treatment do not seek out care. So in 2019, only 10.3% of individuals with any substance use disorder received treatment, and only 44.8% of individuals with any mental health problem received treatment. These low rates of treatment seeking have not improved, despite the rising rates of behavioral health disorders in the general community. Even if we develop highly effective treatments for every behavioral health problem, we will not see success if the people who need treatment are not showing up in our offices. And not seeking out care when it is needed can have serious implications for many individuals. As you can see at the bottom here, one study found that only 40% of individuals who attempted suicide in a given year had received treatment in that year. And that's despite the fact that a large percentage of those individuals indicated that they needed treatment. So these data highlight the importance of us understanding the motivations and the barriers to treatment seeking, and to use that information to develop interventions that may increase treatment seeking behaviors. So Dr. Tracy Stecker at the Medical University of South Carolina has devoted a significant portion of her career to understanding help-seeking behaviors among individuals with various behavioral health problems. She has used the theory of planned behavior to understand people's motivations for seeking treatment. The theory of planned behavior posits that individuals' intentions to seek treatment depend on their beliefs about treatment, including the process and the outcomes of treatment, their cultural community's perceptions about treatment or the treatment system, and their perceptions of barriers to getting treatment, such as cost or the time investment. These beliefs influence if an individual develops an intention to go get treatment, such that those with more favorable beliefs about treatment are more likely to seek it out, while those with less favorable beliefs may not. So Dr. Stecker has conducted several research studies that have demonstrated that an individual's beliefs about treatment actually predict whether or not they seek out professional services. Therefore, using cognitive theory to examine treatment seeking as a behavior, it follows that an individual's intention to seek treatment can be increased by modifying their beliefs about treatment. So combining the theory of planned behavior and cognitive theory, Dr. Stecker developed an intervention called cognitive behavioral therapy for treatment seeking, CBT-TS. She first used the theory of planned behavior to identify what the common beliefs are that predict treatment seeking among samples of hearing individuals, and then developed the intervention by applying CBT techniques to modify those beliefs. So the ultimate goal of CBT-TS is to encourage individuals to seek treatment for their behavioral health problems. To do that, providers use CBT techniques to explore and modify an individual's beliefs about treatment and provide them with accurate information to better understand the treatment process and goals. Providers accomplish these goals using a variety of different techniques in the session, including exploring the individual's current beliefs about treatment, re-examining their beliefs with strategic questioning, directly providing information or correcting faulty beliefs, working with the client to modify their beliefs and develop more favorable views of treatment, and collaboratively problem solving real barriers to getting treatment. One thing to note is CBT-TS is not designed to function as a therapy session. So it does not focus on an individual's symptoms or their presenting problem. Instead, the focus is on the client's treatment-seeking beliefs and behaviors. The CBT-TS is a single session intervention that can be conducted on the phone or face-to-face and lasts about 45 to 60 minutes. And it targets the beliefs that influence whether someone will seek out treatment. The intervention is individualized in the sense that the content discussed with each client will differ based on their unique beliefs about treatment. But the intervention is structured in a similar way for all of the clients. So the intervention begins with a pre-session assessment of the client's beliefs about treatment, using a measure that Dr. Stecker developed called the Perceptions About Services Scale. That scale assesses the common beliefs about the process and outcomes of treatment, barriers to getting treatment, as well as community perceptions about treatment. So the provider will review the client's responses prior to the session, as well as any background information they may have about the client, and then schedule a session. The intervention session itself is divided into 4 phases. So it begins with a review of the client's symptoms and current functioning. What are they experiencing? Which parts of their life have been impacted? Just getting to know them better, where they're at right now. This information is used to establish a need for treatment and highlight the potential impact for that client of delaying treatment any longer. In the second phase, the provider assesses the client's past and current methods for coping with the symptoms they're experiencing. So what has worked for this person and what has not worked for them. This information is used to clarify any limitations of the client's current coping methods and highlight what treatment can provide. The third phase is the meat of the intervention, the longest portion. And during this phase, the provider works with the client to modify their faulty or maladaptive beliefs about treatment, provide accurate information about treatment, and problem solve any realistic barriers to increase the likelihood that the client will seek treatment for their symptoms. And finally, in the last phase of the intervention, the provider and client develop a short-term action plan, which will detail changes that the client plans to make to address their symptoms and current functioning in the short term. So CBT-TS has shown promise as a tool to increase rates of treatment seeking among individuals with various behavioral health conditions. On this slide, you can see a couple studies that I picked that highlight the efficacy of CBT-TS in doing several things. Accelerating treatment initiation, meaning people will go to treatment earlier than they normally would. Encouraging treatment engagement, they go and continue to attend sessions. And reducing symptoms of behavioral health disorders through treatment. So you can see that this has been used on a couple of different behavioral health disorders so far. We see PTSD, alcohol use disorder, and even obstructive sleep apnea. There are several other trials that are out there that are currently underway and more evidence, but these are just a few I chose to highlight right now. So like I said, currently CBT-TS is being used in several clinical trials with participants with a variety of behavioral health conditions. One such trial is actually being conducted here at the University of Rochester Medical Center, led by Dr. Connor and Dr. Stecker. That trial is examining the efficacy of CBT-TS to promote treatment initiation and improve drinking outcomes among individuals with untreated severe alcohol use disorder recruited from the community. Interestingly, during the data recruitment phase for this trial, the study team received several calls from deaf individuals with severe alcohol use disorder wanting to be included in the trial. So this prompted the team to search for a deaf team member to expand their study to meet the needs of those deaf individuals. Luckily, at the time, I was completing my internship with the Deaf Wellness Center in the Department of Psychiatry here at URMC. And through his research, Dr. Connor got in touch with me, and we ended up describing a desire to expand his study, and happened to fit my career goals perfectly. So based on our discussions, we decided to apply for a diversity supplement to allow me to train and work with this team. Dr. Connor was awarded the supplement in September 2020, and since then, I've been working closely with this team to adapt CBT-TS to meet the unique needs of the deaf community. So today, I will review some of the work I've been conducting to adapt CBT-TS, some preliminary findings from the studies I've done, and my future plans for this work. Before I begin discussing my postdoctoral project, I want to clarify which group of individuals I will be talking about today and provide some background information about the deaf community. So in general, in this presentation, I'm referring to the group of deaf and hard of hearing individuals who are involved with the deaf cultural community. Although the general society typically views deafness as a disability, many deaf individuals consider themselves as part of a unique socio-linguistic community, which has its own language, cultural values, and customs. The deaf community has its own organizations, schools, news outlets, art, comedy, etc. And I'm sure that many of you watching today have some knowledge or experience with the deaf cultural community, because we live here in Rochester, which is actually one of the largest deaf communities per capita in the United States. However, more often than not, clinicians and researchers are unaware of the existence of deaf culture. Therefore, deaf individuals have generally been excluded from cultural research studies. They've also been excluded from clinical intervention research, often due to their disability status, their need for accommodations, or their lack of fluency in English, which disqualifies many individuals based on clinical intervention inclusion criteria. Therefore, the deaf community remains one of the most understudied populations in behavioral health research. In fact, at the current moment, there are no evidence-based interventions for this population. So research shows that deaf individuals have several unique factors that actually place them at a higher risk for developing behavioral health problems. For example, most deaf individuals are born into hearing families, and more often than not, their families do not learn American Sign Language. This means that many deaf individuals struggle to communicate and connect with their own families, as well as with hearing individuals in the general society. So this may result in limited social support and isolation, which we know are significant risk factors for developing behavioral health disorders. In addition, deaf individuals often experience discrimination and oculturative stress, which are also risk factors. And not only that, many deaf individuals struggle to access health information, as there is almost no health information sources available in American Sign Language, and there are very few providers who can communicate directly with deaf patients in their native language. So these risk factors contribute to some of the behavioral health disparities that exist in the deaf community, where we see higher rates of depression and anxiety, higher rates of suicidal ideation and attempts, nearly double the rates of trauma, and triple the rates of hazardous drinking. So, as I previously mentioned, it is well known that among the general population, a major barrier to treating behavioral health disorders is that the individuals who need care don't go to treatment. Deaf individuals may be even less likely to seek treatment than hearing individuals due to several cultural and linguistic factors, such as having limited access to health information, fear and mistrust in healthcare settings due to histories of cultural and linguistic oppression, barriers to communication with their treatment providers, and a general lack of culturally and linguistically appropriate services for the deaf community. In fact, during the screening assessments for my postdoctoral project, only 21% of the deaf individuals that I screened who met the criteria for one or more behavioral health disorders were connected to treatment. So this data highlights the need for interventions that may increase treatment seeking among deaf individuals and reduce some of the behavioral health disparities we see. So we know that CBT-TS is showing promise as a brief, low-cost telephone intervention that can increase treatment seeking in hearing individuals. However, it was not developed to address the unique needs of the deaf community. And as I previously mentioned, there are no current evidence-based interventions that have been developed or tested on deaf individuals. Therefore, little is known about the unique needs of deaf individuals or the factors that may have to be modified or incorporated into treatment protocols when working with deaf individuals. However, some clinicians and researchers who work with deaf individuals have noticed and documented a need to modify some of the existing evidence-based interventions we have. Generally, their modifications have included addressing specific barriers such as communication or English literacy limitations, health literacy deficits, and also incorporating cultural formulations and sociocultural characteristics of the deaf community into treatment to make it more relevant for those individuals. All right, so it's likely that CBT-TS would benefit from adaptations to make the intervention more relevant and specific to the needs of the deaf community. Since CBT-TS was developed by identifying the beliefs that predict treatment seeking among the general population, an important first step to assess the applicability of that treatment for the deaf community is to identify the beliefs and barriers that predict treatment seeking among deaf individuals. This information could guide the adaptation of the intervention measures and content, as well as allow for the incorporation of cultural formulations into the manual and training materials for providers. So with the diversity supplement from the National Institute on Alcohol Abuse and Alcoholism, I focused my postdoctoral project on adapting CBT-TS for the deaf community. To provide a structured approach to the adaptation, I chose to use the adaptive model, which offers a pragmatic framework for adapting evidence-based interventions. The adaptive model consists of 8 sequential steps that you can see listed on this slide. My postdoctoral project focuses on the first 6 steps of this model and will result in the manual, materials, and procedures for the adapted intervention to be used with deaf individuals. I will go through each of these steps, highlighting the progress I have made to date during my postdoc, as well as my plans for the remainder of my time. And then I will briefly discuss my future plans to complete those last 2 steps of the model with the URMC CTSI KL2 award I received. So the first step of the adaptive model is called assessment. The goal of the assessment phase is to assess deaf individuals' beliefs about behavioral health treatment, assess the applicability of CBT-TS for the deaf population, and gather information about what adaptations may be necessary for CBT-TS to be relevant and useful for the deaf community. To achieve the goal of the first step, I conducted elicitation interviews on Zoom with 16 deaf individuals with severe alcohol use and behavioral health problems to learn more about their beliefs that may predict treatment seeking. You can see the inclusion criteria for my study here on the slide. Participants for the elicitation interviews were recruited from Facebook by advertising specific deaf cultural group pages. Interested participants then scheduled a brief screening assessment with me on Zoom, during which I collected demographic information, reviewed their treatment history, administered several behavioral health measures to assess for alcohol use, depression, anxiety, and PTSD to ensure that the sample I got consisted of deaf individuals who were in need of treatment. The elicitation interviews followed the theory of planned behavior and elicited individuals' behavioral beliefs or beliefs about the likely consequences of getting treatment, normative beliefs, or the beliefs about the normative expectations about treatment in the deaf community, and control beliefs, or beliefs about the perceived barriers and facilitators for seeking treatment. So step one of the project is complete, and I will show you some of the data that I have now. I received a total of 111 inquiries from interested participants. 69 of those participants were screened, and 33% met the inclusion criteria. So the large majority of individuals did not meet the inclusion criteria due to an insufficient level of alcohol consumption. And the rest, which was a small minority, did not qualify since they were already connected to treatment. Of the 23 individuals that qualified for the study, only 16 were interviewed, 12 males and 4 females. 5 of the eligible participants did not complete the informed consent, 4 because they did not respond to schedule their informed consent session, and 1 declined to participate. 2 participants who consented for the interview did not show up for the scheduled session, and we were unable to reschedule. In this table here, you can see some of the mean values for the behavioral health measures that I collected. And notice that the audit scores for the sample are all in the severe range, which was part of my inclusion criteria. So they range from 16 to 32 with a mean of 22, all reflecting severe alcohol consumption. But in addition, you see the sample means for depression, anxiety, and PTSD were all above or close to the clinical cutoffs for moderate levels of symptoms. So after completing the participant interviews, I had the video recordings interpreted into spoken English. The interviews were conducted in American Sign Language, and that was interpreted into spoken English and then transcribed for the purposes of data analysis. A research assistant and I then coded the written transcripts to identify themes following the theory of planned behavior. So here I will show you the main themes we've identified, broken down by the 3 different belief types from the theory of planned behavior. And I'll also show you some example quotes from the participants. But for the purposes of this presentation and the limited time I have, I'm going to focus on the negative beliefs about treatment that may be preventing deaf individuals from seeking treatment. So for the behavioral beliefs here in this table, or these beliefs reflect the likely consequences of getting treatment. Well, many of the participants expected to experience negative effects if they attended treatment, such as increased stress and frustration. And they said that this would mostly be due to experiencing discrimination within the treatment system, or having to deal with hearing providers who cannot communicate with them and don't know anything about their culture, or having unqualified interpreters, etc. And they feared that this stress would ultimately lead them to drink more and exacerbate their existing mental health problems rather than treating them. Similarly, the participants questioned the effectiveness of treatment, given that their providers would likely not be able to understand their unique issues as deaf individuals, and they believed that attending treatment would ultimately be a waste of their time and money. So not necessarily that they didn't have time or money to go to treatment, but that if they did, it would be useless and wasted. Another interesting theme that came up was a fear to quit drinking, as it could lead to a loss of community. So deaf community spaces are typically small, and the community members are very tight-knit. Often, deaf events are held in spaces where alcohol is served. So therefore, the deaf participants feared that if they quit drinking, they would lose their connection with the deaf community in their hometown, and then would be further isolated due to not having many other options for close relationships. So here you can see an example from one of the participants of a behavioral belief they reported. I'll give you a little time to read it. So you can see from this example that the patient believes that attending therapy will lead to stress from having to deal with a therapist who are unaware of their cultural and linguistic background, and who likely will not appropriately accommodate them for treatment. and not having to deal with that stress would prevent them from actually getting help for the original problem. In terms of normative beliefs, or the beliefs about the normative expectations of treatment in the deaf community, the participants stated that alcohol use and treatment are not frequently discussed within the deaf community, and there are less prevention materials that are geared towards their community. So they explained that treatment also is not encouraged due to deaf individuals' negative experiences in the healthcare system. And finally, the participants discussed concerns related to some community dynamics. Given the small size of the deaf community in their home states, they feared that the information, if they were to go to treatment, that information would be spread around like wildfire and would ruin their reputations. And this was really common among deaf individuals who were in leadership positions or higher up in organizations where they were well known in the community. They feared that it would ruin their employment or their marriages. So they were concerned about that kind of community dynamic. Here's an example of a normative belief that was reported by one participant. I'll give you some time to read that. So you can see from this example that the deaf participant feels as if there is not much accessible information about therapy or treatment options within the deaf community. And thus treatment is not often considered or recommended as an option as readily as it would be for hearing individuals. Finally, for the control beliefs, or beliefs about perceived barriers and facilitators for seeking treatment, the participants described several barriers for seeking treatment, including myths about alcohol use and treatment, not knowing what treatment options were available to them, not trusting the treatment system, experiencing discrimination from providers, having limited options for deaf culturally competent treatment, communication barriers with providers, and having limited resources to obtain treatment. The participants, interestingly, also questioned the competency of both hearing providers and deaf providers. So for the hearing providers, their concerns were related to the lack of knowledge about deaf culture, ASL, and cultural factors related to their health. For the deaf providers, the participants were concerned about the fact that maybe those deaf providers didn't have as much specialized training as the hearing providers did. Finally, several of the deaf participants mentioned concerns related to confidentiality and multiple relationships with the providers, given the small size of the deaf community and the likelihood of sharing similar social circles with their deaf providers. They were concerned that if they did choose to go to a deaf therapist, that they might know that therapist, or they might see them out at deaf events, or they might know someone who knows the therapist or the interpreter who shows up for the session. They might know them. There's a lot of concerns related to that. Here are a couple examples of control beliefs. So in the first quote, you can see that the participant feels as if the therapist she may be able to see are not going to be familiar with her cultural background as a Black deaf woman. And she's going to have to spend a good amount of time educating them before they can even help her with her presenting problem. In the second quote, the deaf participant is explaining that there are so few options for deaf therapists in their state that it makes it almost impossible to find a good match. But in general, deaf individuals who prefer to see a deaf therapist may only have 2 or 3 therapists to choose from. and that limits their ability to find a therapist who actually specializes in their presenting problem or with whom they feel like they are a good match on a personal level. Finally, the third quote is an example of deaf participants' concerns regarding the multiple relationships and confidentiality. So this person explained that they had finally found a therapist with whom they could communicate directly, but then it turned out that they already knew the therapist on a personal level, and then they weren't comfortable attending treatment with that person. So after completing the first step of the adaptive model, the assessment, I moved on to step 2. Step 2 is called decision. And this involves reviewing any potential evidence-based interventions to address the problem at hand, deciding which evidence-based intervention to select, and deciding if the evidence-based intervention should be adopted or adapted for the target population. So in this case, CBT-TS has already been identified as a promising intervention for increasing treatment seeking among individuals with a broad range of behavioral health problems. And thus, it may be useful for increasing treatment seeking among deaf individuals. The results from the assessment in step 1 of this project suggest that the large majority of deaf individuals who screen positive for behavioral health disorders like alcohol use, depression, anxiety, and PTSD are not seeking treatment. In addition, deaf individuals report problematic beliefs about treatment that do align with the theoretical underpinnings of CBT-TS, and they have been shown to predict treatment seeking among hearing individuals. So it follows that modifying those beliefs may increase rates of treatment seeking among deaf individuals, similar to how it does with hearing individuals. However, the deaf participants also reported several unique beliefs and barriers based on their cultural and linguistic perspectives. So those unique characteristics need to be incorporated into the materials, content, procedures of CBT-TS to ensure the relevancy and usefulness for deaf individuals. So that is my decision to choose CBT-TS and also adapt it for the new target population. Now, step 3 of the adaptive model is called adaptation. And the overall goal of step 3 is to adapt CBT-TS, the intervention for use with the deaf population. So the first step involves conducting what we call a feeder testing session of the original CBT-TS intervention before it is adapted. So using this methodology, I plan to host 2 separate focus groups to provide a demonstration of the CBT-TS intervention. So I'll provide a focus group for the members of the target population, and then also what we call key stakeholders in the community, which will be any behavioral health professionals who may provide this intervention in the future. So this step is currently in progress. I developed a script that was based on real experiences of CBT-TS with hearing people. And then I filmed a role play that showcases the main components and techniques of the intervention. So during the focus group sessions, I will introduce CBT-TS, including a brief explanation of the rationale, goals, materials, and structure. And then I will show the participants the film demonstration. After watching the film, the participants will complete a brief survey on RedCat to provide feedback on the intervention and whether it's applicable to the deaf community. Finally, I will lead a group discussion with all of the participants to gather their feedback regarding the appropriateness of the intervention for deaf individuals and what adaptations to the content, delivery style, or materials should be considered for the deaf community. Oh, sorry. Okay. So here I can show you a brief 5-minute clip of the film demonstration that I made and plan to show to members of the focus group. This clip will show you parts from the 3rd phase of the intervention, the meat of the intervention. So it demonstrates some of the questioning techniques that are used to encourage clients to re-examine some of their beliefs about treatment. One note before I start it, there's no sound on this video because the film was done in American Sign Language. but I have captions on the screen. If you are not fluent in ASL, you can just read the caption, okay? So I'll play this. Okay, So with that clip, you can get an idea of the content and format of the intervention. The participants in the focus groups will watch the entire demonstration with clips from all 4 stages of the intervention and then look over all the intervention materials. Afterwards, they will be engaged in group discussion about the possible modifications to the intervention to increase the applicability for deaf individuals. Well, step 4 is called production, and it involves producing the first draft of the adaptive intervention. So the information that was gathered from the elicitation interviews and then from the theater testing sessions will be combined and used to inform the adaptation. The adaptation process will involve balancing the need to maintain fidelity to the core elements of CBT-TS and the underlying psychosocial theory with the numerous priorities that emerge from the elicitation interviews and the theater testing sessions. So based on the data I have collected so far, some possible adaptations to the intervention that I'm considering include updating the pre-session measure to include treatment-seeking beliefs specific to deaf individuals, incorporating deaf cultural formulations into the intervention manual, adding a treatment information pamphlet with descriptions of treatment options and expectations of the process, adding a list of treatment-seeking resources specific to culturally appropriate services for deaf individuals, creating ASL versions of all the intervention materials, and possibly adding a follow-up session to provide additional assistance with deaf clients who would like to seek treatment. Step 5 of the adaptive process is topical experts. And this will occur after I'm done with the first draft. I will identify 5 professionals with expertise in deaf mental health, alcohol use disorder, substance abuse, and/or clinical interventions with the signing deaf population. The experts will review the content of the adaptive intervention, including any of the written or signed materials, and then provide feedback on the draft. In addition, I may also ask some of the consultants to assist with identifying or developing, reviewing any potential valid, reliable, culturally appropriate measures to be used in future testing of the intervention to assess outcomes. So step 6 is very straightforward and simply involves getting feedback from the experts and integrating it into a second draft of the adaptive intervention. And step 6 will mark the end of my postdoc. So at this point, I will have the manual materials and procedures of the intervention drafted and ready for testing with deaf individuals. So once the CBT-TS intervention is ready for feasibility and pilot testing with the deaf community, I plan to use my URMC Career Development Award to allow me to continue my training in clinical intervention research and complete the final steps of the adaptation process. Well, I will begin my KL2 project with step 7 of the adaptation process, which involves recruiting and training study personnel to assist with pilot testing of the intervention. So I will train study personnel in study protocols, recruitment and retention of participants, assessment and interview techniques, and data management. Step 8 of the adaptation process is called testing, and it involves 2 discrete steps. The first step involves conducting a pilot test of the intervention with a very small sample of the target population to assess the acceptability and feasibility of the intervention. This pilot test serves as a dress rehearsal of the adaptive intervention, and it will assess the adaptation efficacy, or how well I adapted the intervention for the deaf community. So the intervention will be administered to members of the new target population, and then we will conduct exit interviews with each of the participants to gather their feedback on whether the intervention was relevant, useful, and appropriate. The information gathered during this study will be used to refine and develop the final version of the adaptive intervention. So this is what I plan to do during my KL2 award period. The second step of testing involves conducting a randomized controlled trial of the adaptive intervention to assess its efficacy among the new target population. And I plan to continue with this line of research as I develop my career as an independent clinical researcher. All right, so that's the end of my presentation for today. Thank you for your time and attention, and I will stop sharing my screen now.
Thank you, Aileen. That was really interesting and a great presentation. And right now, there are no open questions. So, oh, here's some comment from our chair. And it says, excellent presentation. My question is my question is a little tautological. CBT-TS targets patients who are reluctant to seek treatment. How do you motivate reluctant patients to engage in CBT-TS? Isn't that the goal of CBT-TS to begin with?
Right. So it is kind of ironic. These patients don't want to go to treatment, but at the same time, we are providing an intervention to them. So far, what I have seen with CBT-TS, how it's been implemented, it has been through advertising. Because a lot has been through research studies. So we have posted advertisements on Facebook, on social media of any kind, with slogans saying, do you want to talk about your beliefs about treatment? Or do you feel like you might need it, but you're not sure yet? And many people do reach out. And not all of them will go to treatment, but they appreciate that ability to just talk about what their thought processes are so far. And I noticed even with the people who I interviewed, that was the kind of slogan I use on advertisements for recruiting people to talk about what problems they've noticed or what they're experiencing. People appreciate that. And when they came, they may not go to treatment after, but they mentioned that the process was very helpful to them and they were not aware of all of the resistance they had. So I imagine it can be simply by advertising in the community, a hotline where someone's there. I've seen hotlines set up in the VA for people who have suicidal ideation, so they can call and talk with the therapist about whether or not they should go to treatment, what their options are. So that's how I imagine it being set up now. Or providing to specific organizations where they see individuals. For example, in the deaf community, many deaf individuals go to vocational rehabilitation. So within that organization, we could train the counselors there, the VR counselors, and how to do CBT-TS. And when the opportunity comes up, when they're talking with someone who may need treatment or not, they could utilize that intervention.
Okay, thank you. I have a question, and that is, a lot of the work I do and people I work with is with people with psychotic disorders, who often are very reluctant to seek treatment. Some of the people are considered to be at risk for a psychotic disorder or have a newly diagnosed psychotic disorder. Have you thought about extending your approach to that, those populations?
I do imagine it could be extended for that population. It would be interesting to see how their beliefs about treatment align with what we've already found from the behavioral health disorders we investigated. But I assume that there may be a lot of overlap there too. In like, I don't need treatment, or I don't have the time to go, or not trusting the system, not wanting to follow doctor's orders for that reason. I imagine that it could be applied. May, depending on the level of severity of that patient, or maybe incorporating some caregivers or parents or family members into those sessions where talking about options and their beliefs. I think it would be useful. And I think it's all about finding that person, what their underlying belief is, and trying to modify it with them, and also showing some of the benefits of going to treatment, what could be offered if they go.
Yeah, we have a project now happening with people recovering from a first episode of psychosis where the treatment engagement is very poor. So I may be contacting you about trying something with people who are deaf with some of those issues. Okay,
I would love
we
that.
have time for one more question, and coincidentally, we have one more question. And this is from Kim Van Orden, who says, given that there are no evidence-based treatments for mental health in the deaf population, if you find that your intervention works to promote treatment seeking, where would you want to offer CBT-TS? Would you offer it only somewhere like URMC, where we have the Deaf Wellness Clinic?
I would imagine CBT-TS would be offered nationally. That's my goal. Okay. Oh, I'm sorry. I got distracted myself with the interpreter. Sorry, signing and thought it was someone else. Okay, my thought. I think it would be offered nationally. It can be simple through phone on the phone. So it is just about encouraging people to reach out to treatment. So I imagine this can be a hotline. It can be instituted within different organizations that are already serving deaf individuals. It can be in the community. It doesn't have to be tied to a clinic. Just as long as we're able to provide resources to follow up. And that is something that I want to include in the adaptive intervention, is help deaf individuals find those culturally appropriate services. And we do have some available that we can connect, virtual treatment for deaf individuals that are deaf-run organizations, or hearing therapists who know sign language. As long as we have a list that can help people find that treatment, then I imagine CBT-TS can be applied nationally.
Okay, I'm going to try to squeeze in one more question. It has to be a short answer. This is from Will Pigeon.
Okay.
Can you say what conditions individuals in the deaf community are most likely to seek treatment for and least likely?
I'm not sure we have that official data, but I can't tell you with any certainty which ones are more likely to go or not. I would assume it probably follows what we see with hearing individuals, but I'm not sure.
Okay, thank you. And finally, just one last comment from Ben Lee, that there's tremendous generalizability of CBT-TS to many marginalized communities. For example, linguistically isolated immigrant communities.
I agree.
Okay, so I want to thank you again for an excellent, interesting presentation. And I'm glad you got that KL2 and you'll be sticking around. And, I think, like Dr. Lee says, there's a number of applications of this work, possibly to populations that you haven't really thought about yet. So it should be exciting in the future. All right, thank you everybody for coming today. And remember to fill out the evaluation, and we'll see you next month. Take care.